Welcome to the Docs Who Lift podcast, where we distill and simplify the complexities of a healthy lifestyle, exercise, medicine, and weight loss. We're excited to bring you a podcast that's a prescription for clinical practice, scientific recommendations, and just real life. This is the Docs Who Lift podcast.
Hey, and welcome back to the Docs Who Lift podcast. I'm your host, Dr. Spencer Nadolsky, with my co-host, Dr. Karl. And we have one of our favorite guests back, Dr. Grant Tinsley. He's an associate professor at Texas Tech University and actually my new chief science officer at Vineyard, where we're doing body composition studies in those taking the GLP-1 medicines. And he is can we say world-renowned? He's going to be humble. Look at him.
If you want to flatter me, I guess I won't push back on it.
World-renowned.
You're at least renowned.
Expert.
I saw
renowned.
you published in the big endocrine journals.
Yeah.
So in my world,
and those journals are all across the world, and the internet goes to different countries. I don't know. I think you're world-renowned.
Thank you. I'll take it.
Body composition expert. We've had him on, and actually we learned a lot about how DEXA scans and the different compartments. If you haven't listened to those podcasts to understand how you can measure body composition, I suggest going back. We may go over some of the review here, but this whole podcast is supposed to be about this new paper that came out looking at the fat-free mass and lean mass losses, which we're actually going to get into this terminology again in those taking Tirzepatide. It was a sub-analysis of the SURMOUNT-1 trial, which we've talked about often, which is Tirzepatide for those with obesity, not the Mounjaro brand for type 2 diabetes, but those with obesity. And so we're going to get into that today. So welcome, Grant. Also, we can go over kind of the study that we're doing together to kind of tease this out as well, since our favorite Dr. Attia, it's a big running joke because we always make a joke about him on this podcast, but he made the claim a couple of years. Actually, I think the memory just popped up.
It's
2
been
years
a couple
ago.
of years. Yeah,
he made the claim on Megyn Kelly.
Right. And because that was the Wegovy trial, just like what we're looking at today, it was a sub-analysis of the big Wegovy trial, essentially. And it suggested that lean mass loss was a little bit more than what would be expected kind of across the board for the amount of weight loss. So he started the sort of mythology that, oh my God, all these medications reduce muscle mass. And that's when we had you on to clarify that that's not exactly the case.
And so this is all about Tirzepatide. And so first and foremost, can you go over the terminology? Because he was saying lean mass loss, but there's fat-free mass loss, and they're using, and in this paper, they actually distinguish the vernacular, the nomenclature of this. And you've sent me a few good papers on this recently. Could you go over that?
Yeah, especially
I'd be happy
the
to.
lean mass versus muscle mass deal, because I know that's what people
mass.
Fat-free mass, lean mass, muscle mass. That's what people conflate, and you do the best job at delineating that.
Yes.
Well, yeah, thank you. I appreciate that. It's, it's interesting that the terminology is important because, of course, if someone's reading it, they need to know what is being discussed. And I will say this new paper does a good job. They include a table on definitions, and they also include the data you need. This is another issue. The terminology people use is one issue. But sometimes if the terminology is fuzzy, if the complete descriptive data are there, you can double check if you know what they're talking about. And I'll explain what I mean by that. So in that regard, this paper did a good job there. But essentially, so starting at the top, we have body mass, just total body mass loss. That will be comprised, if we split that into just two buckets, fat mass loss and fat-free mass loss. Now, fat-free mass is the ideal term. It's just referring to everything that is not fat in the body. So fat-free mass. Where things get fuzzy is in particular this term lean mass. And, it's funny because I've had the pleasure of working with Dr. Steve Heimsfield, who I know you're both very familiar with, on a few papers recently where like our sole purpose was defining these terms, looking at this historically, like what do these terms actually mean? How are they being used? And just trying to parse all this out. So kind of the essential features there are that, again, fat-free mass, all the molecules in the body that are not fat. And when we're talking about fat, we're talking about this from a chemical perspective. So we're talking about, if we want to get technical about it, these non-polar lipids. So we're not talking about adipose tissue at this point. We're just talking about all of the molecules of fat in the body, wherever they occur, that's fat mass. And then all the non-fat molecules in the body, that is fat-free mass. Now, this terminology is affected by what techniques we're using to assess body composition. So this trial and several of the trials that have had these body composition subsets use DEXA, dual energy X-ray absorptiometry. And this is one of those techniques that's trying to separate the molecules in the body. So one of the kind of main outcomes DEXA can provide is called lean soft tissue. And it's similar to fat-free mass, but we've actually also removed the bone mass. So DEXA is very good at estimating bone mass. So now lean soft tissue is all the mass in the body except for fat and except for bone. Now, the technical term here, again, is lean soft tissue. And again, the authors do a good job clarifying that when they say lean mass, they mean lean soft tissue. The issue is that the term lean mass is used all over the literature. And, in our recent papers looking at these definitions, we essentially recommended against using it unless you're just kind of generally referring to things that are non-fat or non-adipose. But from what we've seen in the literature and even how this term developed historically, it does not have a singular definition for an exact body compartment. So again, these authors, they do clarify that they mean lean soft tissue, and they have the data that allow you to calculate this. And what I mean here is that they show the total body mass at baseline. They show what they call lean mass at baseline and the fat mass. So if you add up their lean mass and fat mass, you see that there are a couple kilograms missing from total body mass. And those couple missing kilograms are bone. So not only did they define their terms, which is great, but they also provided you the data to double check that and say like, okay, I see they're actually reporting lean soft tissue when they say lean mass. But in many other trials, they both don't have the data for you to do that double checking. And then they also use fuzzy terms without saying exactly what they mean, if they're talking about fat-free mass or if they're talking about lean soft tissue.
Yeah, thank God you're a chief science officer, because I would screw that up if I would screw that up. No, it's really this is why you need experts that actually understand this without just kind of going, everybody's losing lean mass when they're talking about fat-free mass, and they didn't actually look at the soft lean tissue.
And more so, they're literally saying muscle, which again, your paper with Heimsfeld, I think is very great for, endocrinologists, obesity specialists, because it really does. It helps to delineate those things out and say, okay, this is what we're really talking about. And why is muscle not necessarily how people conflate the two. And there's so much more to adipose tissue than just the triglyceride fat mass, so any nerd clinician out there.
Yeah. So that's even
Journal of Endocrinology.
Absolutely. So that's even the bigger issue. So what I just described up to this point, it matters being precise on the terminology. If we're doing a meta-analysis, something like that, we want to know if it was fat-free mass or lean soft tissue. So it matters some, but we're kind of talking about, a few kilograms of bone and just clarity and best practice and so on. The issue you bring up is much, much bigger, which is that skeletal muscle mass is not the same thing as lean soft tissue mass or as fat-free mass. So these are completely different ways of understanding the body. Everything we've talked about up to this point, we're talking about just the mass of different molecule classes in the body. So all the triglyceride molecules, it doesn't matter where they are. It doesn't matter if they're in adipose tissue, if it's intramuscular triglyceride, that DEXA scan is going to see it as fat mass because it's just looking at how these X-rays travel through body tissues, how much they're attenuated, but it doesn't matter where those fat molecules are. If we're talking about kind of anatomically defined tissues, we could dissect off a cadaver like adipose tissue and named specific skeletal muscles. Those are a completely different way of understanding the body. That's called the organ tissue level of body composition. And that's what we'd assess through different imaging techniques like MRI or CT scanning. But we can't from DEXA. There's some equations you can use to try to get an estimate of skeletal muscle mass from DEXA. But if you're just looking at what's reported in these papers, like whether it's called lean mass, fat-free mass, lean soft tissue, none of those should be interpreted directly as muscle. There's some overlap in the molecules contained in each of those items, but they are certainly not the same thing. So we tried to, in the paper you mentioned, we tried to kind of delineate that. And this hasn't been looked at in detail in the context of, obesity medications, but from some really detailed prior weight loss research, they've actually simultaneously used these gold standard methods of estimating fat-free mass loss and also some of these techniques like MRI, looking at the actual tissue loss. So from that, we can kind of piece things together, and that's one of the things we tried to explain in that paper. And I can run through just like one example here, just to contextualize this. So this is kind of hypothetical calculations. This was not with the recent Tirzepatide paper. This was with the previous Wilding semaglutide paper. But we were looking at like where they reported 6.9 kilograms of fat-free mass loss. If you tried to determine how much of that kind of overlapped with skeletal muscle using kind of these proportions we've seen in this prior detailed research, it came out to about 4.2 kilograms. So about 60% of that fat-free mass loss would overlap with skeletal muscle. But then you could break it down even further and see how much of that was water from skeletal muscle and how much of that was protein. And we got down to the point, if from this total, 6.9 kilograms of fat-free mass loss, what we were estimating would be less than a kilogram of actual skeletal muscle protein loss. And I think going down to that level of granularity is a little bit helpful, because I think people, if they hear, the fat-free mass loss and they see a large number and they equate that with muscle loss, they picture, the proteins, actual functional units of muscle just melting off the body. And it's like, okay, we're not going to be able to function. And I know you all have great clinical perspectives on that, where you've seen patients whose, and this is reflected in the literature too, but their physical function is improved. And they're certainly, not having this catastrophic disability from muscle melting off them during these treatments.
Yeah. Unfortunately, that's what the influencers out there want everyone to think. They all use literally everyone's losing muscle. I mean, and from Atia to Hyman to our favorite friend Jillian. Right?
Oh, God.
They all say that.
It all comes out of a place of fear that their livelihood and jobs. I mean, like, when you're selling whatever they're selling, they don't want these things to be good, because I don't know. They're buying. They also, it seems, to have a weight bias. So I think it's really important to know this. What is expected? We've talked about this before, but because this is what everybody thinks, that these drugs are specifically catabolic, and catabolic meaning breaking down of muscle tissue, specifically beyond their caloric deficit properties. What's to be expected?
Yeah, so I will give you the number. There's, of course, a lot of context and nuance at the individual level. At the group level, the benchmark that we often look for or think about is about 25% of weight loss coming from fat-free mass, or, in some cases, lean soft tissue. The difference is a few kilograms of bone there. But that's kind of a benchmark. Again, there's a lot of context there. But interestingly, the Tirzepatide paper that just came out, the Look paper, it was right there. It was at 25, 26%. A big meta-analysis also came out recently with a few thousand patients that also found across a number of different specific medications and number of different doses and so on. But they found fat-free mass loss of about 25%. So again, you can get this lower with appropriate lifestyle intervention. You won't always get that to 0% fat-free mass loss, but it's at least a helpful benchmark to say, like, okay, is this a little more than we would see with other types of interventions or not? And really, that was the major outcome, the major kind of conclusion of this paper we're discussing, is that this is really on par with what's seen with other modalities of weight loss, and it doesn't seem that there's a disproportionate loss. And it was even similar to what was seen in the placebo group here, which was just, a targeted reduction of 500 calories a day and increasing physical activity to 150 minutes a week.
We hypothesized about the semaglutide, why it got to around 39 or so % fat-free mass loss. Fluid, we just don't know. Is that right?
Yeah, I'm not aware of anything that has really detailed that mechanistically.
Yeah. So we're doing a case. We're going to be publishing a case study because we took patients that, not all my patients got DEXAs. I actually want to get into that, and I don't know if you know any literature about this. My brother and I are not against over testing, but kind of, in terms of like
Sure.
Is it going to change your management? So DEXA scans are one of those things where it's like, is it going to change our management? Is it going to change that we want our patients to optimize protein and lift weights?
Other body comp things too. I mean, I'm going to get a Sika, a body comp thing. So will it help people? That's what we want to know.
So, right. So just knowing it, well, anecdotally, now that I've been doing these, if we have our little study going on, a lot of my patients are getting DEXA scans, and it's motivating them. I swear, again, you have to do what is called an RCT, where you'd have to randomize somebody to not a DEXA scan to others and see if it actually influences their behavior. But I swear that it's helping people go, I want to lift weights because I want to improve this, or I want to be able to track this. We have a case series that we're going to publish where, I wasn't pushing DEXA scans before, but these patients happen to have gotten DEXA scans. They were heavy, they really got into the lifting, and their fat-free mass losses were minimal. And it's it's a case series. That's why we're doing a larger study. But as Grant said, there are some lifestyle interventions, which we are docs who lift. So we promote lifting weights. We're kind of meatheads, so we promote a lot of protein.
We might be. I think it's going
to be interesting.
Selection bias, because
I know.
we also tend to attract patients who are more leaning that direction oftentimes. And obviously, we are. People think we're shills for the medicines. Actually, we're shills for the strength training. Hence the name of the podcast. And I'm literally, as you guys can see, I'm moving into my new clinic, literally called the Endocrine and Diabetes Clinic at the Gym. Like that's our thing.
A gym. It's like literally in a gym, isn't it?
Yeah, literally in a gym. Yeah.
It's literally in a gym.
Anyway,
okay.
So we're a selection bias.
Yeah, it is true. I think people come to us because they're like, we like lifting, and so that's probably the case. And they're probably going to.
But we want everyone to lift. Cradle to grave
as well. Okay, Dr. Tinsley, what other little tidbits from this paper are worth sharing? Anything else? I mean, basically, so I do want to mention Tirzepatide is about 30 or 40% stronger than semaglutide. And despite that, it seems to be less fat-free mass loss. So I don't know what's going on with semaglutide, but anything else from this?
Probably make that nuts. Oh, boy, that's hot because it's such a small sub-analysis of the huge, it's like 160 patients out of like a few thousand, so I don't know.
Yeah. So a few thoughts. One on the case series and the patients you attract and all that. That probably is true with some selection bias, but at the same time, I think it's a good demonstration of what is achievable, even if it's a small group, even if it's the people who really bought into the lifting and protein and so on. I think that is an additional data point to support that there's not this unavoidable disproportionate melting of skeletal muscle off the body. But yeah, in terms of this study, there are always, I think it's a good study. It's a good analysis. There are always, some things to note about any study. One thing they mentioned outright is that there was no specific strength training component. So participants both in the placebo and treatment groups were encouraged to kind of meet standard physical activity recommendations, but there was no detailed reporting of their activity levels or strength training participation. So certainly, even though this is good, the results are generally good, showing, not a disproportionate amount of fat-free mass loss. Like you said, down the road, RCTs that are really involving, starting with some of these case studies and observational work we're doing, and then evolving into RCTs. When we have that structured resistance training, we'll see how far we can push this towards maintenance of not just fat-free mass, but skeletal muscle specifically, and also looking at muscular performance and function. Some of these questionnaires they use are nice, saying, okay, in general, physical function improved, but ideally we would do some actual testing where we're getting numerical data on force production and muscle performance in some of these things. Some other caveats, there were 28 different DEXA sites here. So, they did a decent job describing the guidance they gave to each sites, but they did use different types of DEXA scanners. There were 28 sites across multiple countries. So, there's this trade-off here. It's maybe generalizable because you have people from all these areas and you're having, assessments at all these different locations. But it was in that regard less controlled than something happening at a single center. But that's just kind of the the nature of research.
They didn't have
So
the same did they talk about the software they used or anything like that?
they also allowed the use of both GE and Hologic scanners, and they didn't even specify an exact model. They just said that they could use GE or Hologic scanners, and there are multiple types of scanners. With that said, they did say within a participant, they asked the sites to use the same scanner and same software model.
Okay.
So because they were focusing on change values over time, that's reasonable. It's not perfect from a methodology perspective, but there's always this trade-off between what's perfect on paper and what's actually feasible, what you can actually do.
Yeah.
Beyond that, the only other thing, they did some interesting sub-analyses by sex and age and so on, but the sample sizes there got very small. As was just mentioned, the overall sample size here, I think, was 160. And then once they split this into, smaller and smaller groups, they did a good job not over-interpreting there, but generally they saw pretty similar results across these different subgroups with different degrees of weight loss, different age, and so on. So we would really need a much larger analysis to parse out if, some of those factors like age and degree of weight loss with treatment truly influenced outcomes they were looking at.
Yeah, that's pretty interesting.
Wasn't it
like
a couple
rate
of
of
years
weight
ago,
loss.
Spencer? Wasn't it 2 years ago when we literally put together a randomized controlled trial protocol for Lilly?
Yeah, we did
for Tirzepatide with strength training versus standard recommendations. It turns out we got shot down. As if
why would we let these idiots? No, we were going to do it with Brad Schoenfeld. Schoenfeld was going to be
he was
the primary investigator on it.
We had it already. We still have the protocol. We have it ready to go.
We were going to call it Surmount Resistance, and they go, they're really excited about it. And they said, unfortunately, we went with somebody else. And I was like, yeah, do you guys even lift or what? Oh, Lilly. I know. You know what? We say it on every podcast. The Lilly people are listening. There's some scientifically. Go tell them to give us some money to run one of these things.
Yeah, it was a great trial protocol.
It was
Come
a
on,
good
guys.
trial.
Jeez.
We can have Dr. Tinsley do all the the ultrasound, the muscle ultrasounds, and all this different stuff. Because what they're doing now, they're trying to come out with drugs that are muscle sparing and if not muscle building while people lose weight. And I'm skeptical because when you artificially build or keep muscle, is it going to be functional? Is it going to help? I don't know. I'm skeptical, but
I will say that the one that we talk about the most, that's the farthest along, has been studied in sarcopenia.
The Magramab.
And it looks really good, and it has been studied in diabetes, which of course is a more severe metabolic complication of obesity, and with benefits there. So we know there's some hints at metabolic benefits from the medication.
Functional. I think there were some. They showed not so much.
And that goes to this trial that we're talking about, but also the semaglutide Wegovy trial that had at least the perception of more than what was expected fat-free mass loss. And despite that, and certainly in this trial, everyone on the medication who had substantial weight reduction had improved everything, every parameter of health you could imagine. And that includes all their cardiometabolic stuff, their blood sugars, their blood pressure, their lipids, but also their physical function and their quality of life, which I think is, that's really like if we didn't measure, they wouldn't even know. And we still need everyone to lift weights, no matter what happens. So that's always kind of my conclusion.
Every single day, I have patients that say, I wouldn't have been able to exercise with this weight. Now that I'm starting to lose weight, I feel good. And now I feel like going and lifting weights and walking more, biking, and even running and whatever else. So I do think these medicines, when used properly in the right indicated populations, really facilitate that behavior change that people want. It's like the fitness people that get really upset. It's like, no, this actually going to help. Like, you should be happy because you're going to probably have more jobs because you don't have to worry as much about the nutrition. Just help them lift weights. Honestly, I think it's
that's a great
smart
point. They should embrace it, and hopefully
some of them are. Some
trainers
of them are.
do here.
Yeah, very good. All right, do we have anything? Oh, what are some cool studies, Grant, that might be down the line? Like, we could run a randomized trial on creatine. I want to know how to do a placebo of that. I guess you can do like little capsules.
Yeah, you could do, depending if you're doing powder or capsules or whatnot.
Yeah.
Creatine wouldn't be the hardest since it can be like a white flavorless powder. It's a little bit easier for a placebo. Or you could flavor it and just have the flavored placebo. There are lots of fun ways we could.
Spencer loves
do that,
white flavorless powder.
Powder.
But yeah, I mean, there's all kinds of ways you could look at this. You could try to isolate one factor at a time, like the resistance training, the ideal protein intake, creatine, and so on. Or you could go the whole thing and say, like, okay, we're going to do a whole best practices for muscle lifestyle intervention. And we have the, ideal resistance training. We have this targeted protein intake. We have creatine. We're throwing the whole thing out. It's like, this is what we would tell someone who's like, I want to build muscle, and have that whole comprehensive muscle lifestyle intervention. It could be pretty simple. It could be those three things. And then versus standard of care. And that would give you this nice overall look. I think that would be very important, very generalizable. If you wanted to scientifically, you could parse those things out and try to determine how much benefit is from each. But I'm not certain that's necessary if we know there are multiple, interventions with very strong evidence for supporting muscular health, performance, function, and so on.
Very good. All right. Anything else?
I don't think so. It's always a pleasure talking with you both.
Yeah, and you're a great chief science officer, because this stuff's cool. I just think this is, kudos to Peter Attia for bringing this stuff up and giving us content to talk about. But it's important. It's a good clinical question.
Sure.
And we're we are part of answering that. Obviously, the other researchers are doing it as well. So thanks, Dr. Tinsley, for coming in and explaining the different nomenclature and all that. Because every time I learn something too, because I'm not a DEXA expert, I just learn from you and the others. So if you want to follow Dr. Grant Tinsley, you can find him on Instagram. Where else are you?
So primarily Instagram. I have a personal website that just has information about my lab and work and so on. And that's just my name, granttinsley.com.
Perfect. We'll put that paper in the show notes as well. Here's our outro. Share with a friend. Oh, what is this? Oh my God.
Oh no.
This podcast is for entertainment and education and information purposes only. Remember, the physicians on this podcast are not your physician. It should not be considered professional or personalized medical advice. It should not be used to replace speaking with your physician or medical professional to discuss your specific health concerns. The topics discussed should not be used solely to diagnose or treat any condition. As a result, we are not responsible for any unwanted medical outcomes. The views and opinions discussed are of those of the host only and do not represent those of any other entities.